welcome to the Journal of the American Society of Echocardiography podcast. Editor-in-Chief Dr. Michael Picard, Managing Editor Deborah Meyer, presented by myself, Amer Johri. The first article is a brief research communication appearing online on the JASE online website ahead of print. From Doppler to Dante, Common and Avoidable Malfeasance in Echocardiography. Abandon all hope, ye who enter here, by Dante Alighieri, The Divine Comedy. In the Divine Comedy, the Roman poet Virgil guides Dante through the gates of hell, 9 concentric circles within the earth that increase in wickedness. Just as Virgil guided Dante with human reason through the gates, we hope to shepherd you, armed with evidence and common sense, around everyday sinful echocardiography practices that may creep into the uninitiated lab. The following article is by Dr. Nelson B. Schiller and Jonathan M. Wong and appears online on the JASE website. Doomed to failure before you even begin. Fundamental to obtaining quality images is the positioning of the patient and sonographer. While some scanners position themselves on the patient's right side, we think this is suboptimal. Not only will the scanner struggle, but reaching around the patient will invite unwelcome intimacy. Steep left recumbency is best achieved from the left side with an apical cutout mattress. Right-sided scanning brings us to our next sinful practice, point-of-care ultrasound, performed by the uncommitted novice. Unleashing POCUS has opened Pandora's box. This has empowered some non-cardiologists to deliver improved real-time clinical care. However, the uncommitted POCUS discipline risks poor image quality or, worse yet, harmful incorrect clinical interpretation. While we are all novices at one time, the uncommitted POCUS disciple remains in a nefarious purgatory state without hope of progression. Equally egregious is the titular limited study. These studies are ordered often by those who rarely know what they want to be limited, and performed by those who are never sure what to leave out. This results in studies that are more difficult to interpret than they should be. Another common practice that creates more difficulty is the omission of critical information in the indications for study. Too often we find the innocent left ventricular function or murmur in patients with significant cardiac history, such as prosthetic valve and heart transplant. Perhaps reserved for the 10th circle is the omission of blood pressure. It is regrettable that an experienced echocardiographer would undertake the interpretation of an echo without knowing the precise BP at the time of the examination. Critical to hemodynamics, evaluation of ejection fraction, left ventricular hypertrophy, aortic stenosis, mitral regurgitation, ventricular left to right shunts, to name a few, BP should be in the reader's mind from the beginning of each study. Despite hectoring, complicity in an industry-wide refusal to integrate BP into echocardiographs appears entrenched. On Doppler. Apart from augmenting specific diagnoses such as cardiac tamponade for constrictive pericarditis, Doppler sweep speeds are often too slow to assure reproducible measurements. As Virgil may quote the Aeneid, we shall quote the ASC guidelines. All velocity and time interval measurements should be performed at a speed of greater than or equal to 100 millimeters per second. Again, we see the complicit hand of industry in that the default Doppler sweep setting is often 50 millimeters per second or slower. Perhaps more abhorrent is that of omitting specific Doppler signals altogether, namely pulsed wave of the pulmonary vein flow and continuous wave of pulmonary regurgitation. Pulmonary vein flow provides a wealth of information, including left atrial pressure estimation, MR severity, and LV diastolic function. The signal of pulmonary regurgitation is most informative, as the opening and closing velocities supply close estimations of mean pulmonary artery and end diastolic pulmonary artery pressure. When reporting Doppler signals, we often read reports stating peak velocities without the velocity time integral. Few markers in echo are as powerful outcome predictors as LV outflow tract VTI, or as informative as TR-VTI. In the grading of aortic regurgitation severity, LVOT-VTI is often ignored. Significant AR almost always has an elevated LVOT-VTI, while the pulmonary VTI is normal or reduced. The peak LVOT velocity, in contrast, does not incorporate ejection time and therefore does not represent stroke volume. Increased stroke volume is an obligatory feature of hemodynamically important aortic regurgitation. Temptation to shortcut. A single echocardiogram rarely stands alone for long, as there tends to be a correlation between the number of echocardiograms performed and the severity of cardiac pathology. An interpretation without a comparison is simply deficient. Similarly, a sonographer without knowledge of the prior study leads to incompleteness. If contrast was used or strain imaging performed on the prior study, their absence in the current study leaves much to be desired. Studies that do not include a maximum depth clip in the initial parasternal long axis are another sin of omission, as they obscure heart size by filling the screen with the image. More importantly, a shallow setting hides a pleural effusion. A word of caution in using the copy-paste or set all to normal features on your echocardiography reporting system du jour. This feature is also treacherously effective at perpetuating incorrect statements of echocardiography interpretation. Transgressions in echocardiographic reporting. In the subcostal view and suprasternal views, beautiful images of the aorta are often obtained. Yet it is rare that the reader will bother to comment on aortic plaque, despite cardiology being more attuned to plaque than any other specialty. Other clinically important findings that are often not reported include abdominal aortic aneurysm, ascites, and right pleural effusion. In the occasional case where the inferior vena cava is not well visualized, the reader will often claim that the right atrial pressure cannot be estimated. This is false if there is either a reasonable hepatic vein or superior vena cava Doppler signal. Too often, in mitral regurgitation, the S word, or severe, is used with abandon, when the MR is in fact not severe. Examples include late systolic MR in mitral valve prolapse and A-dominant mitral inflow pattern where the MR is never more than moderate. Now that patients have access to their echo reports, we need a substitute for the S word. Finally, while reporting linear dimensions has its role, failure to report volumes of the left cardiac chambers is akin to echocardiographic delinquency. This is supported by our guidelines, and in our practice, we look at the measured volumes of ventricles and atria before we see the images. We have presented our pet peeves when it comes to echocardiography. We hope these practices dismay you, just as the sights and sounds beyond the gates dismayed Dante. While this report solely reflects our own opinions, we believe avoiding these practices will elevate the standard in your echocardiography lab. By Nelson B. Schiller of the University of California and Jonathan Wong of the California Pacific Medical Center. The next article is an audio long read entitled Transcatheter Aortic Valve Replacement and Left Ventricular Geometry, Survival and Gender Differences by Vien Truong and his colleagues. This article appears in the November 2020 issue of the Journal of the American Society of Echocardiography. Aortic stenosis is the most common acquired valvular heart disease in developed countries, with a prevalence of 9.8% at ages 80 to 89 years. Transcatheter aortic valve replacement, or TAVR, is indicated for patients with symptomatic severe aortic stenosis with high or intermediate estimated surgical risk. And TAVR promises to be the primary method of aortic valve replacement in the elderly population. Severe AS causes a marked increase in LV afterload with resultant LV hypertrophy, which is considered an adaptive response to normal LV wall stress. However, the presence of LVH is often associated with increased cardiovascular morbidity and mortality, both in hypertensive populations and in patients with severe aortic stenosis. In patients with hypertension, LV mass is an independent predictor of long-term cardiovascular events. In addition, the geometry of the left ventricle further stratifies risk, with concentric LVH associated with increased cardiovascular mortality compared with other patterns of LV geometry. In patients with severe AS undergoing surgical aortic valve replacement, concentric LVH with a markedly increased relative wall thickness, or RWT, has also been associated with increased mortality. However, this relationship is not as clear, as a recent publication from a large database showed no significant relationship between baseline LV geometry and clinical outcomes in TAVR patients. The present study was designed to further investigate the prognostic role of baseline LV geometry and to characterize changes following TAVR. Methods. Patients. This was a single-center retrospective analysis of 265 consecutive patients who underwent TAVR for severe aortic stenosis between May 2011 and May 2015 under the approval of the Institutional Review Board of the Christ Hospital, Cincinnati, Ohio. A total of 206 patients were eligible for inclusion after 59 patients were excluded because of inadequate echo data at baseline, or who death during TAVR hospitalization occurred. Of the 10 patients who died during hospitalization, baseline echo showed 2 patients with concentric LVH, 3 with concentric remodeling, and 4 with eccentric LVH, and 1 with normal geometry. Of 173 patients alive at 1-year follow-up, 13 patients had adequate echo data. The following demographic and clinical variables were collected for each patient, including age, sex, body mass index, body surface area, blood pressure, hemoglobin, GF, and GFR. In addition, the presence of comorbidities such as hypertension, diabetes, coronary artery disease, AFib, COPD were also recorded. Assessment of LV geometry. LV mass was calculated according to the methods described by Devereaux et al. LVH was defined as a LV mass index greater than 95 grams per meter square in women and greater than 115 grams per meter square in men. Patients with increased LV mass can have either concentric or eccentric hypertrophy. Concentric hypertrophy is defined by a regional wall thickness greater than 0.42, whereas eccentric hypertrophy is defined by regional wall thickness less than 0.42. LV geometry was stratified into one of the following groups. 1. Concentric hypertrophy. 2. Eccentric hypertrophy. 3. Concentric remodeling. And 4. Normal geometry. Clinical outcomes. Outcomes are obtained by periodic monitoring via telephone calls and/or follow-up visits. All patients were assessed for the development of new events. 1-year all-cause hospitalization and all-cause mortality were also collected. Results. Patients. Among the 206 study patients, the mean age was 82 years. 186 patients underwent balloon expandable valve implantation and 20 received self-expanding valves. No differences were found in LV geometry between the two valve types at baseline, at 1 month, or at 1 year. Among the 4 geometric subgroups at baseline, there were no significant differences in age, hypertension, diabetes, coronary artery disease, AFib, COPD, peripheral vascular disease, GFR, and hemoglobin. Among the 4 LV geometry groups at baseline, there were no differences in the use of ACE inhibitors, ARBs, beta blockers, calcium channel blockers, and diuretics. Similarly, at 1 month and 1 year, no differences in the use of ACE inhibitors, ARBs, beta blockers, calcium channel blockers, and diuretics were found. A total of 47 patients underwent pacemaker implantation after TAVR. There were no differences in pacemaker implantation rates among the 4 LV geometry groups. Echocardiographic parameters. The overall group's mean baseline aortic valve area was 0.66 centimeters square. Changes in the mean values of end diastolic and end systolic volume, as well as peak gradient and mean gradient, LV mass index, and LA volume index were statistically significant after TAVR and follow-up. However, overall, EF did not change significantly. Among the 4 subgroups, there were no differences in baseline LA volume index, valve area, EF, MR, or AI. There were significant differences in baseline interventricular septal end diastolic thickness, LV internal diameter in end diastole, and LV posterior wall end diastolic thickness, LV mass index, end diastolic volume, systolic volume, peak gradient, and mean gradient. The proportion of moderate or severe paravalvular leak was 5.6% at 1 month and 6.3% at 1 year for the overall group, but there was no significant association between LV geometry and paravalvular leak at 1 month and at 1 year. The changes in LV geometry during follow-up are shown in Supplemental Table 1 and Figure 1. The highlights show that the distribution of LV geometry was statistically different between male and female patients at baseline, but not at 1 month. Other highlights include that the baseline concentric hypertrophy conferred a survival advantage after TAVR. LVH seemed to regress, but was largely due to concentric remodeling geometry after TAVR. LV geometry as a predictor of survival. At the end of the follow-up of a mean of 3 years, 121 patients, or 59%, were alive. Cumulative event-free survival in the whole study population was 84% at 1 year, 69% at 3 years, and 59% at 6.5 years. A statistically significant difference in survival was observed across the 4 LV geometry groups at 1 year that was more pronounced at 6.5 years. At 6.5 years, patients with concentric hypertrophy had greater survival than other groups. Concentric hypertrophy versus normal geometry showed that the p-value was 0.018 for survival. There were no differences in index hospitalization length of stay or hospitalization rate over the 1-year follow-up period, although patients with concentric hypertrophy tended to have fewer hospitalizations. Associations between various clinical and echo parameters and mortality are further presented in the Supplemental Table 2. In summary, at baseline, univariate analysis of all-cause mortality showed several associations. In the multivariate Cox regression analysis, the Society of Thoracic Surgeons score greater than 8, history of cerebrovascular accident, concentric remodeling, and normal geometry were independent predictors of mortality out to 6.5 years of follow-up. Concentric LVH was associated with a lower rate of all-cause mortality compared with patients with other forms of LV geometry. In subgroup analysis compared with patients with concentric hypertrophy, patients with normal geometry had higher rates of all-cause mortality. With regard to the association of valve type with mortality, our study showed that the valve type was not significantly associated with mortality. Discussion. The main findings of this analysis are that 1. Concentric left ventricular hypertrophy geometry at baseline is associated with better clinical outcomes after TAVR compared with other geometries. And 2. After TAVR, LVH regresses, but largely to concentric remodeling geometry. And finally, 3. There appears to be a gender association with patterns of LV geometry with aortic stenosis that resolves after TAVR. Our study showed a relationship between subtypes of LV geometry and all-cause mortality in patients with severe AS undergoing TAVR. Patients with concentric hypertrophy had better clinical outcomes compared with those with other geometries, better survival, and tendency for fewer hospitalizations. This association was marginally apparent at 1-year follow-up, but more pronounced at longer-term follow-up. Varshni et al. Recently reported no significant differences in terms of mortality among LV geometric patterns after 1 year. The reason for this discrepancy include a longer follow-up period and careful, more accurate measurements of all echocardiograms in our study. Our findings suggest that LV mass index and regional wall thickness on their own were not associated with long-term mortality in patients after TAVR, which is in agreement with a previous study. There are obvious parallels between aortic stenosis and hypertension, as both conditions represent afterload to the heart. Although in hypertensive populations, concentric hypertrophy is consistently associated with poor outcomes, our findings in patients with aortic stenosis appear to be contradictory. Factors that may underline these apparent divergent findings in hypertension and aortic stenosis include the different time courses of increased afterload and the resolution between aortic stenosis and hypertension. It is possible that with more rapid onset of afterload associated with aortic stenosis, hypertrophy may be associated with less fibrosis and more reversibility. Furthermore, the development of concentric hypertrophy in response to increased afterload should be viewed as an adaptive response, the absence of which can lead to adverse outcomes. In hypertension, the association between concentric LVH and poor outcomes may indicate that LVH is more a marker of hypertension severity than a specific geometric response to afterload. As a form of afterload, hypertension is more likely to be variable in severity, intermittent, and dynamic in contrast to the inexorably progressive afterload as seen in aortic stenosis. Furthermore, treatment effect and resolution of afterload are likely quite different between the hypertensive and aortic stenosis population. TAVR is a far more effective, rapid, and complete method to unload the heart than medical treatment of hypertension. Our studies show that LVH generally regresses, but largely assumes the concentric remodeling geometry after TAVR. Moreover, only about half of patients with concentric LVH showed significant LV mass regression after 1 year. Several recent studies have demonstrated persistent LVH after TAVR due to the presence of significant myocardial fibrosis. For example, Wiederman et al. Showed that myocardial fibrosis did not reverse 9 months after aortic valve replacement, as measured by MRI. These data support the need for longer follow-up to assess the relationship between baseline geometry and outcomes after TAVR. Our analysis revealed that concentric hypertrophy is more likely to be present in women, 55% of women, compared with men, 37% of the population at baseline. Interestingly, this baseline difference disappears soon after TAVR, suggesting that it represents a differential response to the increase in afterload in aortic stenosis. Gender variations in LV geometry and remodeling are not surprising and are described in aortic stenosis as well as other models of pressure and volume overload. However, gender was not an independent predictor of mortality in multivariate analysis, which was consistent with other studies. Limitations. As this was a single-center retrospective study, unmeasured confounders may have biased the results. Our sample size was smaller than that of Varshini et al. However, our patients were consecutively treated with longer-term follow-up. Furthermore, echoes were obtained prospectively and sequentially, adhering to a rigorous protocol for timing and data acquisition. Moreover, we assessed the association of LV geometry with all-cause mortality, but not specifically cardiovascular mortality. Given the retrospective study design, the cause of death could not be accurately determined. Additionally, in this group of elderly patients with multiple comorbidities, competing causes of mortality are likely, and the exact cause of death is usually not clear. Finally, coronary artery disease, induced regional wall motion abnormalities may affect baseline and subsequent LV geometry patterns. Conclusion. The presence of concentric LVH geometry at baseline appears to confer a significant survival advantages at TAVR. Furthermore, different patterns of LV geometry among patients with severe aortic stenosis appear to be gender-specific, with women demonstrating more concentric LVH. After TAVR, gender differences resolve. I would like to again summarize the highlights from this study. Baseline concentric hypertrophy confers a survival advantage after TAVR. 2. LVH regresses, but largely to concentric remodeling geometry after TAVR. And 3. Finally, baseline LV geometry appears to be gender specific, and this difference resolves after TAVR. Once again, this study was by Truong et al. And appears in the November 2020 issue of the Journal of the American Society of Echocardiography. Thank you once again for joining the special Friday series of the JASE podcast. We look forward to presenting another episode of the podcast next Friday, shortly following the release of the December issue of the Journal of the American Society of Echocardiography. Hope to have you join us again at that time. Thank you.